we will have practicals in the afternoon with the real practicals so that we can see exactly how do you solve real problems using economic models. And so we will be, so I'll do the introduction part of it, just 25 or so minutes, and then I'll let my colleague, Professor Muriithi, to do the heavy lifting. Professor Muriithi is a professor at the University of Nairobi. He actually teaches economics and health economics at the Department of Economics and Development Studies. And he has been there for some time. So if you want to understand more about the university, you either see Professor Muriithi or you see Professor Thumbi. They can tell you anything you want about the university. So some of us were struggling why we are using the university. So these are the people you can ask to tell you. So, as I mentioned, economics is about scarcity. Because if you don't have scarcity, then we don't need to actually belabor about economics. And the reason why economics is important is because we have limited resources. We have limited resources, and if we have limited resources, then it means we have to think, where do we put this resource? And that is the whole idea of economics. Because if you don't have scarcity, then you have no use for economics. That's basically the idea. And when we talk about resources, we are not just talking about money. We are talking about resources in its broader sense. Resources can be human resources, resources can be vaccines, resources can be commodities for any other disease and so on. So what we are asking ourselves is, if you have a resource like a vaccine and you have options to put these vaccines to, so you ask yourself, if I put it in one area as opposed to the other, do I get better outcomes compared to the area that I'll have thought of in the initial point? And that is the whole essence of economics. And if you look at, or if you think about it briefly, we make so many such decisions in our lives. Even at our personal level, you have some little money and you have so many needs that that money can be put to. You can decide to pay school fees for your child or for yourself, or you can decide to treat yourself by getting out to a trip and go to another country and so on. So you ask yourself, where is the best place to put that resource? And that the study of how you decide on that is actually the whole idea of economics. And that's why I said economics is a way of life, because on a day-to-day basis we make those decisions. We ask ourselves, I have $100. Where do I put this $100 so that I get maximum satisfaction? And I'm using the word satisfaction intentionally because in economics we like using the word utility to mean the level of satisfaction that you get from consuming a good is utility. Economists do not have a unit of analysis for it. They don't have a measure. It's not in kilogram, but it's just that level of satisfaction. So if I give you 2 bottles of soda and then I ask you to choose between the 2, you will take one. And in economics, I know that when you take the one you have taken, it means you, in your mind, you think that is the one that gives you more satisfaction. In economics, we call that utility. So we don't have a way of measuring how much utility you got, but we can see, we can observe. And so in economics, we try to use those methods of observation to try and find out, if you ask me, so which one gave more utility to this person, I can be able to tell by observing what you are doing. So if we go for tea break and I see you taking muffins and not taking something else, it means in your mind, muffins are giving you more satisfaction. That's basically how we treat it in economics. And this is important because there are many a times you will be asked to rank. So one of the approaches you will see, it bases its decision on how people rank utility they get from different interventions. And in economics, we also have a very elaborate way of studying how people make choices. People make choices by doing what we call pairwise comparison. It means if you have 20 items, you don't just go and then compare all the 20 at once. You do what we call pairwise comparison. You compare 2 items, then you choose one that gives you more utility than the other. Then you take the one that has given you more utility, you compare with the next. If the next gives higher, you leave this one, you take the next. And that process is assumed to happen even when you have 1,000 items to choose from. So it means that when we see you make a choice out of 20 items, it means you have made those pairwise comparisons to the extent that you have ended up with one that gives you the highest utility. And utility is a very important terminology. There are other terminologies we use like opportunity costs and so on, which I think they will be coming as we go along, because this not being an economics class, we will be introducing the terminologies as we use them, so that it's very easy to follow. So in terms of healthcare, now what we are saying is that we narrow those terminologies of economics to health, and therefore we end up with the health economics. So health economics is not really something from the blues. It's basically the application of economic terms to the subject matter of health. So we have terminologies like demand. Demand is when you actually are able to consume something, but that consumption decision is backed by your ability to pay for that item. And so anybody can wish to have something, but we recognize it in economics as demand when you have been able to demonstrate that you can pay for that item. So in real life, what we do is we look at those people who are able to pay for that item. Then we say, then the demand is this. So when we aggregate, put together demand numbers, we are adding those people who are able to pay. It doesn't mean that there are some people who wanted to have that item, but they did not pay, so we exclude them from demand analysis. So it's very important. That's why I said we use so many terminologies and we assume everybody understands them, but it's good to clarify. So what we are saying is that sometimes we use that word demand and need interchangeably, but the two are different, because not everybody who needs demand is able to pay for it. So sometimes we can't observe everybody who needs demand. We only observe those who demanded because they were able to pay, or somebody paid for them. And so it's very important. That's why sometimes when we are doing modeling, we have to go deeper and understand what was the need, because demand is just a portion of the need. But sometimes we use it interchangeably to just show the bigger picture, like over a period of time, what has been happening over demand for some service. And what we are saying is that generally demand for healthcare has been growing. And because it has been growing, the resources available to provide that healthcare are not matching. They are not growing as much as the growth in demand. And therefore, at some point, we need to ask ourselves, where do we put our resource? Where do we put our resource so that we are able to provide the service? And this is important because when we try to imagine where we are putting our resource or our money, then we start talking about the value for money. Meaning you have some dollars to invest in an intervention, and there may be two different types of interventions. So it means you ask yourself, if I put in one intervention as opposed to the other, do I get more value for the resource that I have? And there are studies in economics that look at value for money. So, and this is important, especially when we are looking at money that is spent from public sources, from government. Because remember, in government, if you are an individual and you spend your money anyhow, nobody will bother so much about it. You can decide to take a cab from one street, to ask the cab guy, drop me to the other corner of the street. But if you did that with government money, people will ask, why didn't you walk? Or why didn't you call, and so on. And that's why it's important when we are looking at government spending to actually ask questions about, did we get value for the money that was spent? And when we talk about value for money, it's not just about spending on things like transport. It will also be spending on interventions in the healthcare. You did a mass drug administration. It's called what? Mass drug administration. And somebody else came and said you could have done maybe vaccination in the households and things like that. And then we are asking ourselves, where did we get more value for the money that we spent, and so on. So those questions become very important when we are dealing with interventions, and because it's coming at a time when we don't have unlimited resources. The resources are limited, but the needs and the wants are growing. So we must be able to have a way of getting a way in which we find which of the interventions gives us more value for the money. And that is the whole idea of economic evaluation. We will see in detail as we go into it. And therefore we can use that assessment of trying to assess which one gives us more value to try and pin down on which intervention we could have taken as opposed to the other. And that becomes very important, because I know sometimes we come up with models that tell us that this intervention is actually going to wipe out this disease. But there could be another intervention which can also do the same. So the question is that which one will you take? So this is one approach that we can use to be able to determine which intervention we can focus on. So it's very easy and sometimes very confusing when people accuse economists as people who are very focused on only money, and therefore they think economists are just about money. And to the extent that it has made our life very difficult, because I remember when I was a young man and I was talking to some young girls and they say, you are an economist. And they got so surprised and I didn't know why. I said, I'm told economists, you know, they can never spend even a single cent on you. You know, they cannot even buy you a glass of juice in a hotel. Just because you are an economist, people think that yours is about not spending money, ideally. That's what economists think. But that has been, is actually misperception or misconception. Because the job of an economist is to maximize benefit for given investment. Why should I buy you a glass of juice if there will be something else I could do that benefits you more? Yeah, I can decide instead of buying you juice, I can save that money and add some additional money, and then tomorrow I buy you a dress. See, you are better off with a dress than a glass of juice, isn't it? So because of the way economists think about how to spend resources, sometimes they have been misunderstood to be people who only focus on money. And so while as an economist looking at costs, how much is it going to cost me? There is also the other side of the equation where I'll look at how much is the benefit out of this expenditure. And in economics, we also try to distinguish between expenditure and investment. That's why we use a lot of terminologies as investing in health as opposed to spending in health in most cases, because when you talk about expenditure, then accountants now will treat you just like a road. And they forget that when they give you good health, then you are, according to one economist called Grossman, then you are also able to produce something for yourself, just because you are able to be to feel better, and therefore you are able to be engaged in productive activities, and so on. So as an economist, I'll be basically bothered with both costs and the benefits I get out of that. So it's not just about money. We also consider issues around cost as well as benefits that accrue from that investment. And there are many approaches we use for analysis of economic nature, health economics nature. One of which is to examine costs of an intervention, meaning that we focus our analysis on what are these costs that accrue from this investment or this intervention. And this, we can do it independent of any other item. We can just say these are two interventions. We focus on the costs of this intervention vis-a-vis the cost of this intervention. And that's one form of economic analysis by itself, independent of any other considerations. And it's important to note this because sometimes you don't have information about those other benefits or those other considerations that you need to make, but the only information you have is about costs. And therefore you can do a cost description or a cost analysis just to understand what are the cost area drivers for these two interventions. And you can make a decision on the basis of just analysis of cost. And when we talk of cost, I think Professor Muriithi will tell you later, costs, there are different ways in which we categorize costs. In fact, there are almost 13 ways in which you can classify costs. But for purposes of our discussion today, we will be looking at what we call direct costs, costs that you can attribute to the intervention directly. We also talk about indirect costs, costs that you cannot really directly attribute, and therefore you may be forced to get a distribution key to be able to allocate some element of cost to that intervention. For example, the cost of the Cabinet Secretary for Health to the intervention that you have in mind cannot be really directly attributed to your intervention. So you may take his salary and just take 1% of his salary and then allocate to your intervention and so on. And there are also other costs which we call intangible costs, costs that are not really quantifiable, like pain. You may be having an intervention that gives people pain. I don't know, what is pain in French? What? Douleur. Whatever it is. Yeah, you can actually quantify the pain and call it a cost. So you are saying by providing this intervention, everybody is going limping for 3 days before they are able to heal and so on. And that's why you remember during the COVID vaccination, some people are saying that way of putting something inside the nose was very uncomfortable. So some people will actually just avoid travel because of that, we call it what, the swap. They put it, I remember some lady, you know, we had a window when I was going for a visa, and she's inside the window and she's bringing something, can you move? So you keep moving, then there's somebody else behind who is pushing you now to move. It was very uncomfortable. So that is some of the costs, which is what we are calling intangible. If you have two interventions, one, everything else is similar, but one has that invasive way of getting a swipe out of your nose, then people will actually consider that costly through the intangible cost. And the other way in which we look at it is we can actually look at both costs and consequences. When we talk about consequences, in English, consequence means an outcome of something. But in the correct English, a consequence is something negative. But for purposes of economics, a consequence is both negative and positive. Things that come out of something. There can be good things that come out of it. There can be bad things that come out of it. So we call all those consequences. So instead of just looking at costs alone, you can also look at the costs and the consequences that come out of that intervention. So it means that besides modeling, you also need to ask yourself what will come out of that outcome besides the numbers you just see. And it's therefore vital to understand the different roles of what we call partial and full economic modeling. Because when you just do one element like cost, then we say you are doing partial economic modeling. But when you consider all the aspects, then you are looking at full economic modeling. And we will go briefly to different approaches so that you see clearly. I hope my table is clear enough. It's basically trying to look at, to ask the question, I wish this thing could be moved. I like moving, but now I'm curtailed. Is there a mic that I can use? Thank you. So this appears to be a very simple table, but it's actually the summary of all that you will be doing today, although our focus will just be here, full economic modeling. But what we are saying is that if you have, you ask yourself the question, is there a comparison of two or more alternatives? Like if you have different alternatives. If your answer is no, meaning that you are only looking at mass drug administration, for example, as the only alternative, meaning you are not comparing it with any other, then of course it will fall here. So because we have asked the question, is there a comparison of two or more alternatives? So if there is no alternative, it's only one thing you are doing, it will come under here. Now, when you are here, the next question we are asking, are both costs and consequences of alternatives examined? The answer can be yes or no, but for now, let's look at no. So if it's no, we are only examining consequences. Okay? So for example, we are doing what we call cost examination only. So that will be under partial economic evaluation, where we are only examining costs. But we can also just examine consequences. We assume that costs are okay and only examine consequences. So it will still be examining only consequences. This is only examining costs. So that's why I call it 1A and 1B, where 1A is examining only consequences, and then 1B is examining costs. So it means they are both partial, but only examining one element out of it. But you can also focus on only one alternative, but consider both costs and consequences, in which case it will be a partial evaluation, which we call cost outcome description, meaning you are only looking at one intervention. Remember, in real life, you can easily get situations like this where you are only looking at one intervention and you are being asked, this intervention, how are its costs? So you are not really focusing on trying to compare two alternatives, but looking at one alternative only. Then the question can be, are you looking at the costs of that intervention, or are you looking at the consequences of that intervention? But if you are doing both, then it becomes partial, but you are now looking at both costs and consequences. So the next question will be, maybe if there is an alternative, then it means that you are looking at two or more. Because remember, the assessment will be two or more. So if you have, say, two as a minimum, and when we say two or more, the second one could be a status quo or business as usual. Meaning you have a new intervention and the comparator or comparison is a status quo, not doing anything, for example. Yeah? So it means that the question here will be, is there a comparison of two or more alternatives? So the alternative is there, but that alternative is doing nothing. So it's also an alternative, doing nothing. Very important, because sometimes students ask, what about, we don't have a comparator. We don't have an alternative. But the alternative is doing nothing, because if you have a new drug, the alternative is that you don't have a new drug, any drug. So you can compare what happens when you have no drug and what happens when you have that new drug. So it means that the comparator can be doing nothing or business as usual. And so if you have those two alternatives, then the question we are asking is, are you comparing costs for those two alternatives, or are you comparing consequences for those two alternatives? If you are comparing costs, you will be here. If you are comparing consequences for those two alternatives only, you will be here. They are still partial evaluation because you are only comparing only costs or only consequences. So that leaves us with this quadrant here, where you are now having a comparison of both costs and consequences for the two alternatives. And like I've said, the alternatives can be doing nothing. Very important, because normally when I have this, I feel like I have completed my discussion, because it summarizes everything. But as you will realize, we talk about costing as if it's a very simple exercise. My colleagues whom we have done costing with here can tell you that it can take a whole year to cost some diseases. And sometimes there's no agreement of what the cost is. Even for very clear things like normal delivery. You know normal delivery of a baby? For women, they know. Men, you know what normal delivery of a baby is? If you asked professionals to cost what it costs to deliver a baby, there'll be so many answers that you'll not even believe. People come with different methodologies. There's some who will come and say, look, in that hospital it's 200, in this hospital it's 80, so the average is this. That's one way of costing. There are others who come and say, to deliver a baby, you need gloves, you need a birth attendant, and so on. So when we cost, this is what we get as a cost. They are all right, because it all depends on how they are, which approach they are trying to take. That's why countries spend time first to agree on what approach do we use to cost. Because if you don't agree on that approach, people will cost based on what they are looking for. A private facility will cost based on an average within the area, and then come and say, look, all our facilities, each one is charging this, so we need a minimum of this. Because that is their interest. But the provider who is paying will want to know what exactly is going into the costing. So although we are talking about costing as if it's something very given, sometimes it becomes difficult. Like when you are comparing two alternatives, you need to be aware that the costing that was done, the costing approach that was applied is comparable. Because you could be comparing two alternatives, but one used a different approach in costing, the normal delivery, and then the other one used a different approach in costing. So you get numbers that don't really give the true picture because of the way the costing was done. I needed to emphasize something on costing because the Kenya government now is doing costing of healthcare services for purposes of reimbursement, and there's a lot of discussion in terms of which approach do we use and so on. And so when we consider costs and consequences at the same time for two or more interventions, then we end up with full economic evaluation. So these are terminologies you will find in practice. People use, are you doing partial? Are you doing full? Then you're like, what is the difference? So now you know, isn't it? Good. I'm almost, I didn't want to spend too much time so that we can go into the details. Yeah. So just a quick, because now we will be focusing on the full economic evaluations, the fourth quadrant, like we saw. And there are 5 commonly used, or not commonly used, but there are 5 approaches or full economic evaluations that you will find in the literature. But about 2 or 3 are most common in the literature. So you'll find cost effectiveness analysis, cost utility analysis, and sometimes either cost minimum, one of those will be, but these 2 are the ones you will be seeing in most of the literature that you'll be reading. In actual fact, these two are basically the same. It's just the way you measure the outcome or the benefit or the consequence that makes the difference. Remember, we talked about utility. And so we said if you are measuring the outcome in terms of utility, meaning you attach a utility value. Remember we said, or the economists did not have a unit of measurement for utility. But now people have become creative. They say, can we maybe attach a utility measure, a number on different benefits, and therefore call it utility measure. And that's why sometimes they call it cost and utility analysis, meaning you are looking at cost on one side and the consequence is utility on the other side. And when they look at both for two or more interventions, then it qualifies to be full economic evaluation. It's important to know because there are small things in there in each one of them that Prof will take us through in the course of discussion. But remember, he will not do 100% because these are things like cost alone. I've told you, it takes a whole of, it can take a whole chapter to discuss costing. So there will be assumptions we'll be making so that as you study and read further, you can then discover other things that you can actually use. So let me finally talk about, okay, so we have cost minimization analysis where you are basically assuming that you are either you have information about consequences, but that information is assumed to be given. So you don't need to repeat and do it. And the only thing you are doing is looking at which of the two interventions has least cost. It's called cost minimization analysis. So you look at the costs. Remember we said if you only consider costs, it will be considered as partial. But in this case, it's not like you're not considering consequences. It's just that you already have information about consequences, and they are similar. So the opposite, or the next one, is output maximization. Because in economics, we have two ways in which you maximize outcome or profit. You either minimize costs or maximize output. So we are applying that same knowledge here, that here when you minimize cost, you must be able to get maximum output out of it. Another way is to assume that the costs are fixed somewhere. So how do we maximize outcome or output out of that is to maximize the output. And in which case, then we are looking at, so this is assuming that the consequences are the same. This is assuming that the costs are the same. So you are basically looking at cost minimization or output maximization, because we said that's what we focus on in economics. And in the third one, cost effectiveness analysis, the cost is the same as the cost in all the others, but when it comes to consequences or effect, then we have what we call natural measures, like number of visits, like number of people cured, like anything that you can naturally count, then it will qualify to be cost effectiveness analysis. But then if you end up with what we call cost utility analysis, it means the cost will be the same as the cost here, but in the utility now, you end up with generic measures like QALY. What is QALY? Something that you cannot actually explain to anyone, but you can use it in your models to decide which intervention you want to take. Because there are some things which are very difficult to explain, especially to policymakers. You go and say the DALI is this. They say, what is DALI? For them, they know the number of people treated, the number of patients seen, and things like that. But now when you try to come up with generic measures of utility, then you end up with cost utility analysis. And then of course, the final one, which is normally used in business as opposed to models like what we are focused on, is where you express the consequence in monetary terms. Now it's not about number of visits, it's not about dalis or qualis, it's now how much is it in monetary terms. You look at how many people were healed, and then you convert their usefulness into some monetary number, and then you say if 10 people are healed and each person can work for 10 hours a day, and for each hour he works, he's paid a certain amount, you compute and then you get the value, which is a number. So then you say what is the cost and what is the benefit in monetary terms. So you are now expressing the consequence in monetary terms, in which case it becomes a cost-benefit analysis. They are easy when you explain them the way I'm doing, but when you start doing them, then you realize that you scratch your heads a lot. But I'm sure as time goes by, if you scratch your head so much, we will share our emails, then we can scratch the heads together. So my final discussion is about how do you make a decision? Now that you have done your analysis, how do you make your decision? Remember, I'm doing an overview so that we will go into the details of each later. So if in the cost analysis you have done your analysis and you've found that incremental cost of one intervention is less than incremental cost of the other, then which one do you choose? The one that is higher or the one that is lower? I want to see if I'm communicating. Abdul, which one do you take? Is it the one with the minimum? We are saying IC2 is less than IC1. And then you want to make a decision on whether you take IC1 or IC2. Which one do we take? We choose option 2 because option 2 is less than
option 1.
Option 1 in terms of incremental costs. We will go into the details of what those costs are.
My name is Sering. Abdul is here.
Oh. Then I was calling him and he's swimming. Okay, good. Then in terms of output maximization, the sign changes. It's now the one that has more, because we remember we said you either minimize cost or maximize output. So when it comes to output maximization, the effects of 1 greater than effect of 2 means that we choose option 1. Yes, please.
If we have two interventions with the same output, or if we are reasoning on output,
yes.
How could we introduce the social acceptability of the intervention, or which one should we choose?
Thank you. So that's why I talked about pain. Remember, I talked about pain. So you have 2 interventions.
Yes.
Everything else is similar in terms of computation, but one, they have to put something in your nose.
Yes.
So people don't accept it. So you now look at those other factors that will help you decide. So, and that's a very valid question, because many a times we find ourselves with situations like this where E1 is equal to E2. And therefore we look at other additional information that can then help us make a decision. Because I think when we just go by this, you can easily say take both. But you know, because remember, we are doing this because we have limited resource. So we want to utilize resource where we get maximum outcome or output. So in that case, then you have to consider other items, that factors that will help you make a determination. And one of those, you can go back to your costs and then ask yourself, did we consider the intangible costs? Yeah. And if you did not consider, by considering them, then they can tilt your decision criteria. Thank you very much. That's a very good question. So in terms of cost effectiveness analysis, I wish I had a place to write, because when I was typing, I didn't know this is delta C1 or change. You know, you are modeler, so you are used to these things. Yeah. But when I was typing in online version, I didn't know where to get delta. So it's a flip chart there. Yes. So if I can use it so that because I know how. During our time, we never used to have this. Just so that you know, we had a piece of chalk. You know chalk? White, and then they will paint on the wall. So you write on the wall, a black wall. So you are lucky that we are using this type of technology. So that is the type of analysis we are doing. Oh, good. You see technology now. You can see clearly what I've written. So this is incremental cost of alternative one over the incremental cost of, incremental effect of alternative one. So in the morning when I was scanning, I was asking myself, what does that mean? What exactly does that first ratio mean? You're a modeler, so you can assist me. It was showing here. How come it's not showing anymore? Just leave it there. Somebody is working on it. No, return it there so that it shows. Aha, good. What does this ratio? What do you understand by this ratio? You know, we were told, was it on Monday, that if you do something technical, it wouldn't even assist policymakers. You need to find a way of explaining it to a policymaker. So assume that in your concept note or in your document brief, you have this equation here, or this ratio. And the person, the policymaker that you are talking to asks you, so what does this mean? Are you telling me you will just keep quiet and look at him? So it means that whatever you write, make sure that you understand what you've written, so that when the policymaker, because policymakers will not understand this. It's you who understands it. Yes.
I think that is means the cost for first strategy one, the ratio for the cost effective is less than the ratio for the cost to for the ratio for the cost to bon, the rapport par rapport, comment on dit, rapport de ces deux sur over the cost to over E2, and the best zone is the first the first strategy. Yeah.
Yes, so there is the neighbor who is sitting next to tell us what you have said.
It's it has just said that it's the cost per effectiveness ratio. Which means that the ratio of the first strategy is better than the second ratio.
What do you mean better? It's, you know, when we use this, what is this?
Yes.
Less. Yes. So the first strategy has a small cost effectiveness ratio, meaning you get more effect for an investment you have made. So it means even before you go far, you see that if this ratio is smaller, it means you are getting more effect for the cost you have put in. And remember we said at the beginning that resources are scarce, isn't it? So you want where you spend less and get more. And that's how this ratio can be smaller. Yes?
I have a question. Just if you can clarify the ratio itself, what is reporting?
Yeah, it is reporting, and those are details we will go in. I don't want to to preempt.
Because I have a thinking, but I'm not sure about it.
No, it's the same what you are thinking. Because remember I said incremental, meaning that you look at what you have now and what you have you are going to get by investing. And so what you are additional costs, how much is the additional effect you are going to get? And because it's additional, it must be incremental. It must be a difference. That's why we are using delta to show the difference. These things, they will not be clear today, but as you continue, you will definitely find them getting clearer. Because what is important is how do you interpret what you get out of the discussion? Because if you can't interpret it yourself and convince yourself, then you can't go to a policymaker and convince the policymaker. So it means that you must be able to know that this ratio is smaller than this ratio. And if we look at it this way, if we assume that these effects are the same, when will this sign be maintained? Is when this is what? What will be the relationship between delta dcy1 and dc2 if the denominators are the same? When will this condition hold? I'm asking mathematical modelers. That assume that the denominators are the same. When can this condition hold? Yes.
With the same denominators, when you have the second numerator greater than the first one.
Exactly. So it means that now we are starting to understand. And once we understand, then it becomes easier to explain to others, isn't it? Because it's possible you can get that these two are the same. And we said when the two are the same, which approach will you want to apply? Where the effects are the same. You can decide to do a cost minimization because then you know that the effects are the same and so on. So I didn't want to go into details, but I think I'm being drawn into those details. But I think as you study, I think what is important is to understand the concept from first principles. What I don't like is to be able to answer a question by opening to read before you answer. It means that you did not understand from first principles. You must understand so that when you are asked, you know what it means. So when it comes to cost utility analysis, remember I said there are some generic measurements that are used. One of the most common is called the query. So it means that we can also have, I dropped my pen, you know. Where? Oh, here. So ideally, this is what we have, but as we go into details, you will find that we have the status quo and alternative intervention. AI is not artificial intelligence, it's alternative intervention. So you can have the alternative intervention, the cost of alternative intervention minus the cost of status quo, divided by the query coming from alternative intervention minus the quality from status quo, and you have that ratio. And that is the ratio I'm trying to write here. So it is the delta cost or delta quality. And the same application refers, as what we did in the cost effectiveness analysis. So I just wanted to mention this because after you have done whatever you are doing, you must come up with a decision. And so we are trying to sort of summarize the decision criteria. So you can, at your free time, ask yourself, what if this was, instead of quality is Dali? What will that mean? So that's homework. You can consider that during your free time. Because remember, we are making decisions based on some generic measure. And that measure we have decided either is a quali or is a Dali and so on. So it means you must be able to first to understand what this means before you now make a decision out of it. And even after making the decision, be able to explain to a third person who was not with you when you are doing your modeling. Yes? Okay. Okay. So, first we understand that the generic measure that we are using, remember when we said effectiveness or consequence can be a measure that you can count, like number of visits, people treated, and so on. So when you have that natural unit of measurement, which you can count, then we advise that you use cost effectiveness analysis, because you can easily measure the effects by number of outpatient visits, number of deliveries, number of people cured, number of surgeries done, and things like that. But when it comes to cost utility analysis, that effect is now converted into what you call a generic measure. And that generic measure can be the quality of life, adjusted quality adjusted life year. So what, if you tell your mom, or your sister, that their quality of life year is this, what will they understand you to mean? That your quality of life year, you have 20 quality of life years. What will they perceive you to be talking about? Quality adjusted life year is basically combining mortality and morbidity and then coming up with some unit of measure. What we are saying is that it's very generic. It doesn't mean so much to the ordinary person. It may mean something to you as a modeler, but not to an ordinary person. So it means that first you need to understand it yourself. So the question is that if you have two alternatives, one gives you a quality adjusted life year of 5. The other one gives you a quality adjusted life year of 10. It means that the incremental, the status quo and what the investment is going to add to your quality adjusted life year, we now get a number. So what we are saying that for investing a certain amount of money, one intervention gives you 5 additional life years. In investing in another alternative, the quality adjusted life year is added by 3 years. So it means that you pick the one that the small investment is giving you higher quality adjusted life year. So the question I've asked, what about if it's disability adjusted life year averted? So those are the different ways in which we measure the generic effects. We will get into more details as we do the practicals so that you also understand, but we will not go into computing qualities because we assume that you understand how they are being used. But if you want to understand how qualities are computed, we can meet over tea break or lunch break. We can explain to you because the time will not allow us to go into. That's a whole session. Maybe next time we can have a session to discuss how they are derived so that you know where you are coming from. And of course, I've said that cost-benefit analysis is where you are expressing the consequence in monetary terms. So instead of now just looking at utility or effect in terms of numbers healed, we look at those numbers healed in terms of what they produce and convert it into monetary terms, and then look at cost-benefit analysis. And the decision criteria is also very clear. They go into slightly more details in terms of getting the net present values and so on. And this is important. Actually, after seeing this, let me say something. First and foremost, the benefits over cost. If it's more than one, what does it mean? That you have more benefits compared to costs, isn't it? So it means that if we have two interventions, we can compare those ratios and see which one gives you a bigger number. That's one way. But there's something which I need to mention as I finish, so that I invite Prof to, and I'm sorry I've taken slightly more time. I hope you will be able to move faster. I'm sorry about that. The issue about costing, you know, you can cost things today, and tomorrow or 1 year later, the costs have changed. So it means that you need to be able to account for the variation. Either we call it the time value of money. $100 today is not the same as $100 1 year from now. So it means when you are making comparison of two interventions, you must be aware of when the interventions were costed. If they were costed at 1 year difference, you must be able to discount, so that you are able to compare oranges and oranges. Otherwise, you end up comparing oranges and... Why do they compare them with apples? You can compare oranges and banana. Otherwise, thank you very much. Mine was to give an overview so that we can go deeper into the details of this. Prof, you can... Oh, you have a question? Sorry.
Thank you, David. You know that I'm always enjoying your presentation. For the full economic evaluations, the types of the full economic evaluations, especially the cost utility and the cost effectiveness, as we can report all of them. Like we can report either DALIs, QALYs, or the natural units, like the cases, the infections, the deaths, and so on. Which one we need to choose? And I was thinking maybe because, especially those cost utility analysis, as they are using units like QALYs and DALIs, they are like to allow comparison between public health interventions, like which means that having 10 cancer cases is different than having 10 malaria cases, which means that these measures can correct like this difference, especially if we are placing ourselves in the situation where we are comparing public health interventions with themselves. Don't know if my question is clear.
Yeah, I don't know if I'll be able to answer now, but what you are asking is whether which specific effect measurement you can use, whether there's one preferred to the other. I think the most important is when you are doing comparison, make sure you compare equal things, so that you don't compare one intervention which used number of cases healed, and then you go and compare with another intervention that used a different measure. So that is more important. But then, of course, you also need to look at your effects and then see which one is the most important given the disease. Because if you are looking at COVID, for example, what will be the most important unit of measurement when you are looking at the effectiveness measurements? It can be deaths, it can be a number of cases recovered, something that, you know, each disease has some variable that is normally critical when you are doing a measurement of that disease. If it's malaria, it could be, maybe you're looking at mothers who are recovering from malaria and things like that. So each disease, you will see that each disease has different ways in which we measure the effect. And literature can also guide you If you do some literature review, you then also see the type of effects, how the effects are measured, and so on. Thank you. The question should come after the presentation. Mine was an overview, but
Okay.
please feel free.
Thank you, Dr. So for me, I'm just wondering, the biggest problem we have in the policymakers side, especially when doing planning for health workforce, is that the estimates we give in terms of fiscal feasibility, the political class which make the decision tell us, you people are dreaming. How can we now include these economic models in terms of planning for health workforce, especially when you are using the population health needs? Which of the, maybe the four full interventions which you have given, which can be ideal for planning for health workforce?
So I'm trying to think on my head so that we see like what is, because you need to define your intervention. Because when you define an intervention, then it's easier for us to know what are the costs of that intervention and what are the effects of that intervention. So I think the first thing is definition of your intervention. So if your intervention is to deploy 2,000 additional nurses, and then you start looking at what do nurses do so that you can now measure what the effect is, then that will be one way of looking at it. So to me, I think let's start from defining the intervention. When we define an intervention, it becomes easier for us to get the effects that we want to measure. But I like your question. We can discuss it further so that we get more details. Thank you very much, so that we give Prof some time to take us through the economic evaluation approaches, and if you can reserve your questions, we can ask them when he has gone through them. Thank you, Prof.
Yeah, so yeah, so good morning again. Yeah, so I think I thought Dr. Khaoya was going to introduce. Unfortunately, he has talked about everything. I have nothing to say. Yeah, so I think mine, I don't know, tea break, what time is it? 10:30? Yeah, so 10:30. So I have, I think my work is very easy. Why do I say this? It's easy because I'm only going to put some fresh, some content on what David has told us. And the beauty is I'm dealing with economic mathematic modeler who are not going to ask about that error term. I know that is the hardest when you are talking about econometrics. So I think I'm on very safe ground because mathematical modelers do what we call deterministic kind of model, or what we call exact. So yours is to get 1 + 1 is equals to 2. But as economists, we will say that 3 is not equals to 1 + 2. There must be an error, so we put an error there. Yeah. Then we take all time looking at that error until the policymakers ask us, why is it that you are not sure of the solution you are giving? We tell them because of an error term. We know that nothing can be exact, so there must be some bit of errors when you are doing your measurement. But for mathematical modelers, you have no error, and that is why we call you deterministics. So I'll try to be deterministic today. I'll not go into the error term because the examples I'm giving will have kind of numbers that we will use and also demonstrate how we use those numbers to explain to policymakers, so that policymakers will only understand deterministic numbers, will clearly understand what we are saying. So then my role is to talk about those 3 or so type of economic health economic evaluation. Why health economic evaluation at this point? Why we chose this economic modeling is because after talking with my friend, we were like, what is it that we can introduce as economic modeling? And we are at a loss because when you talk of economic modeling, we have so many, so broad. We have macroeconomic modeling, we have microeconomic modeling, we have agricultural economic modeling, health economic modeling. So then we thought thinking about health economic modeling would be more relevant, more so because SEMA currently is doing what we call health technology assessment for Kenya. So which means that we are using a lot of economic evaluation to do or to bring that kind of knowledge to the, especially to the health sector. So we thought, why don't we why don't we just have a mention of these 4 or so type of economic evaluation? Just like David has indicated, if we wanted to kind of cover cost effectiveness analysis in details, I would have come with that book that is 1,500 pages, which then means that it's a book for you can do a master's in cost effectiveness analysis, just that one. You can do a cost utility analysis training for 2 weeks. You can do cost benefit analysis. Actually, I remember there's a very big book on that. So for us is to give you this concept in terms of how you use them, especially in the areas of health, and also give just kind of a touch so that you can see the numbers. You saw those delta C, delta E. Of course, mathematic modelers will understand, but we also know that we have policymakers here. So we want numbers which you can see exactly what is it that David was saying. Because those symbols sometimes, of course I do teach a lot of mathematics for economists, and I know students who don't love numbers, especially those who are not very good in mathematics. But I think for you, you're enjoying when David was giving those delta. Yeah, so having said that a lot, actually, then I want to mention that we want to look at medical effectiveness. That is key. That is key if we were to talk of health. Why? Because that is where we start from. When you talk of COVID, we are talking of the intervention that you bring there for vaccine. How effective are they? How medically effective are they? So it is important for us to understand what we mean by medical effectiveness and how we do some kind of assessment in terms of the benefit. So we agreed that we are going to look at the benefits, how do we measure benefits in terms of economic evaluation. So that is why we have to choose these 3 or 4 kind of economic evaluation techniques. Yeah, so we also look at cost effectiveness analysis, of course, with some good numbers. Cost utility analysis where David had really struggled, not struggled, but has made a lot of effort to explain what it entails. So we'll even have some numbers which will give you some very, very, very clear understanding of this. I don't know whether you'll have time to talk about cost-benefit analysis because that is where we have the 3 types of cost: direct, indirect, and the intangible cost. but time will tell. Anyway, we'll see whether we need to cover that one too. Yeah, before we move on into this medical effectiveness, I think it is important for us to distinguish between two terms that we use a lot in the area of our medical effect. Before we reach to the medical effectiveness, we have what we call efficacy, is one key term. So when you talk of efficacy in the areas of medical, then you are trying to say that, okay, we have a vaccine that we are testing in a laboratory setup. So how efficient is it in controlling COVID? So how efficient? So that the moment you test, you say it's working very well in a laboratory situation. But that does not tell us much in terms of how it will have impact or effect on the population. So what we do after that, we take that vaccine to the population. We test now with the people. That is in a normal environment, not from the lab environment where it was found to be very efficient, to be working. So when we find that it is working with the population, what are we saying? We are saying that a vaccine administered to the general population will be affected by many things. There will be issues like some people who will not follow instruction. Maybe you are told after taking this, you do this. Yeah, so by the end of the day, that person does not do that. Or maybe talk of even a drug, a usual drug, where you are supposed to take like 3 times in a day. You take in the morning, then you go to work, but you forgot your medicine at home. So you come in the evening and take it. So you have taken twice, 2 times instead of 3 times. So we don't expect that the outcome of that medication will be the same as the lab outcome. So in that case, then we say we are measuring effectiveness because we are working with the real population or with the real person of people. Yeah, so in terms of medical effectiveness, then we are interested with that, not with efficiency as that, but with effectiveness. So we call that one effectiveness when it is working at a normal condition. So so I don't think I need to do that effectiveness. So that's like what I have explained. So that when you talk about medical effectiveness, then we are talking about the realistic. It's realistic in terms of the outcome. Then there are 2 terms that I also want to distinguish here that David was also trying to mention here. 2 terms, and it is very important because if we don't understand these 2 terms, then we'll be confusing our measurement or the way we do our measurements in terms of effectiveness, also in terms of cost. So I think I'm audible enough. Yeah, so this will give me more trouble trying to, anyway. So the idea here is, I'm saying that there are 2 terms. One is output, and the other one is outcome. Those are 2 different terms, but they reinforce each other. And it is very important to start to understand these terms from the onset, because when you are doing your analysis, your modeling, you'll be looking at these 2 terms. When you talk of output, you can talk of output as, say, for example, the number of visits the number of people treated, the number of bed occupied, the number, so we are talking about the quantity of the, which is different from the input again. So you have an input that are supposed to make output. So an input is like doctor time, and he has seen 5 patients. So then we are saying this 5 doctor's time times the 5 patients gives you the output. So, or maybe, yeah, the number that has been treated is the output. When it comes to outcome, we are talking of the goal of the program. So the goal of treatment, the goal of treating people is to make them get healed. The goal of health sector is to control mortality, people who are dying. The goal of HIV program, for example, is to reduce incidence. So these are what we call the outcomes. The outcomes, which are the goals of whatever program you have. So when we are talking about these kind of measures, it is important to know that we use output in order to measure our outcome. For example, and why is it important? It is super important to understand this. For example, we say that we have treated 20 people. Is that one enough? When you say that we have treated 20 people, that's the output. What does it tell us? Are we sure that we have achieved the objective? The objective of treating people is to either get healed, or maybe to reduce mortality, or to reduce illness. So by treating 20 people, we rarely know whether they got healed. So that is why we say that we don't know the outcome. So if you want to know the outcome, perhaps one way is to know, out of the 20 people that were treated, how many came back? So if you say 10 people came back for further treatment, then we are saying that the outcome was not 100% achieved. Yeah, so I think it's important that we distinguish between those two terms. Yeah, so medical effectiveness, how do we measure medical effectiveness? The way to measure medical effectiveness, one way that we measure medical effectiveness, which is evidence-based, is to do what we call random control trials. Random control trials, what is random control trials? Yeah, so by random control trials, we are saying that we have, say for example, in a medical environment, we have 2 interventions. We have 2 drugs, like the way David was saying, that we have a new drug that we want to test whether it is effective or not. So for you to do that, you need to come up with 2 groups. Groups that is going to use, that one group is going to use the drug, while the other group is not going to use the drug, use like the old drugs. So then you administer you do it's a process, because what you do is you create 2 groups. You have what we call the control group and the treatment group. The treatment group is the one that you are going to administer the new drug, while the control group is the one that will use the old drug, for example. Yeah, so so you can give an example of COVID, for example, where you have one group that is vaccinated with a certain type of drug, and another one is not vaccinated. Because for any drug to be tested, it has to go through this kind of a test. So to do that kind of RCT, you need to follow several steps. Number one is you have to randomly administer to randomly get these groups. What are we saying by randomly getting the groups? So you make sure that people who belong to control, I say what we are calling the treated groups and the control groups are selected randomly. So that by chance, so that there is no bias in terms of those selected to enter into any group. So the other thing is that because you have to reduce bias, those who are treating should also not have an idea of which group do you belong to. So just a way of controlling some kind of bias. Yeah. So once you have done that, over time, over a given time period, for example, it can be a year, or depending on how long this drug should be used. Then you compare how effective the drug was in terms of the treated groups. There are significant difference between the outcome of these two groups. So this now will tell you that the new drug is more effective or is just not very different from the other. So we call that one RCT. RCTs are very, very expensive. They are experiment in nature. They are very expensive, for example, because of the way you have to conduct them. They are not just because you are not going to collect secondary data. Number two, you have to have a sufficient sample. Number three also is a time period that you keep following to actually see how the difference between the two groups is actually how the difference is behaving. Yeah. So yes. Age consideration. Yeah, you're right. Yeah, so you have to, I don't know whether I had that. Yeah, you have to look in so many things, in terms of the characteristics. And also in terms of how you do your analysis, we have several ways of doing that, which perhaps we cannot discuss at this point. I think it will require a lot of time. We have what we call difference in difference method. We can also have what we call propensity score matching, or maybe we can also use an instrumental variable. Those are techniques that we use to see where the impact of the drug was actually sufficiently significant. Yeah, so as I indicated, RCTs are mainly used for new drugs, and I said they are complicated and expensive to carry out. And you'll find that in most of our African states, they are rarely used. And if they are used, then we find that they are highly sponsored from donors. Yeah, and also we are saying that the effectiveness will depend on many things. Things like the patient characteristics. For example, you need to discuss. It can be affected by the characteristics of a patient in terms of had they advanced in terms of if you are talking about a treatment, had they advanced in terms of sickness vis-a-vis the others. So I need some water. Yeah, so as I said, when we talk of medical effectiveness, we note that we have to look into the outcomes because those are the ultimate. But in looking at the outcome, then we are talking about what is it, the input that we want to put in there, so that we want to see whether those inputs in terms of interventions are they having any significance, any significance, a positive benefit in terms of the use. And what we do is we use several methods to do that analysis. Difference in difference, we are saying that over a long period of time, you want to be taking how this drug, the differences between these drugs in terms of outcome, instead of like where in some cases you want to look at the end of the experiment. So difference in difference will help you to really add this difference, see whether by the end of the day there is a significant benefit from the new from the new interventions or from the new drug. But I know we also use RCT not only in medical effectiveness, but we also use this kind of experiment in when you want to look at some interventions. For example, you talk of interventions that relate to awareness. So awareness, so you are saying you have an intervention that is creating awareness to some group and not creating awareness to another group. Then you want to compare whether that awareness impact affect significantly the outcome, for example, of breast cancer, where you want to see whether there is a lot of, let alone, more women are going for breast cancer testing compared to those, for example, who did not get the awareness. So it is used in many ways. The only challenge, as we are saying, you have to do a lot of you have to do a lot of in-depth check on the biasness, so that your experiment is not biased by some factors across or within the two. So, for example, the treated group should not in any way know the control. The same also, the control group should not have any information on the treated group. Why is it so? The reason is you want to reduce what we call contamination. Contamination is where you are saying that treatment and the control, when they talk, then it can bring the issue of ethical issue where they start complaining, oh, why were we not given the drug? Why, then it can easily break the experiment. So there are a lot of issues that you need to handle when you are doing the RCT for it to be extremely random, so that the two groups do not have an impact of, say, for example, contaminating each other in terms of information and also changing their behavior. Yeah, so perhaps I would like to stop at that for now. Before then, we can move on to the other areas of cost effectiveness. So this was a way of just trying to bring in the issue, the fact that medical effectiveness is measured through outcomes, and these outcomes, one way to measure that, and one way that we use in the areas of health economics and also other areas, is random control trial. What we call, it's an experiment which takes time, and what we know is that it's also very expensive in a way. Yeah, and like we said, then the issue of value for money, we'll know whether is it worth introducing this intervention. But this value for money, we are going to look at it when we move on to the next area of economic evolution, especially in the areas of health. Yeah, so I don't know whether there is any response for now. I was told to be very fast, but I think I have to slow down now. I try to be very fast.